All right. Assalamu alaikum and good evening, everyone. I would like to welcome you all. I want to introduce myself. I'm Dr. Hazem Aliwa, Associate Professor at the College of Pharmacy, Qatar University, and I'm a member of the QU Health Cluster CPD group. I would like to welcome you all for this event. We have tonight a very exciting topic on pain management practice update, which we have the pleasure to host our speakers, Dr. Nouhad Malik, as well as Dr. Daniel Rainkie. And this basically will be the event schedule. We have first the presentation by Dr. Nouhad, and then moderation, where we'll have some case studies and discussion with Dr. Nouhad as well as Dr. Daniel Rainkie. First, I would like to just give you some hints regarding claiming for the CPD hours. In order for you to do that, you will need to, after the end of the presentation at 7:30, you need to go to the website for the CPD events, and you will need to click on this link where you will be able to evaluate the CPD event and claim your CPD hours. This tonight marks actually the 8th of the CPD events that we had this semester. And actually, we have one more to go for the semester, which will be on December 6th on Parkinson's disease, and will be the last one for this semester as well as for the year of 2021. So without taking further ado, I will just go ahead and quickly introduce our speakers. So we have with us, as I mentioned, Dr. Nouhad, who's a PharmD holder with over 15 years of experience in community and hospital pharmacy between the United States and Qatar. And she was precepting pharmacy students throughout her career. She's currently a clinical pharmacist and acting pharmacy manager at Espitar Hospital. And we have also with us Dr. Daniel Rainkie, who's a clinical assistant professor at the College of Pharmacy at Qatar University. He joined Qatar University in 2015 as a clinical lecturer and is also a clinical pharmacy specialist with the Advanced Heart Failure Clinic at Heart Hospital in Hamad Medical Corporation. Dr. Rainkie completed his bachelor degree from University of British Columbia, and then he received his residency and PharmD degree from the University of British Columbia in 2013 and 2015 consecutively. And he was a neonatal intensive care unit pharmacist before joining Qatar University. Within the College of Pharmacy, Dr. Rainkie is actively engaged in simulation and practice skills, including OSCE development, and he's also leading the assessment committee and contributing to the development and implementation of simulation and non-simulation assessments. His research interests include education techniques, assessment, OSCE, and evidence-based medicine. So without further ado, I will go ahead and leave it with Dr. Nouhad to take us for that journey on pain management. Dr. Nouhad.
Thank you very much, Dr. Hazem, for this introduction, and thank you for having me tonight. So, as Dr. Hazem said, today we're going to have a discussion about pain management, a practice update. The objectives of this presentation will be to first explain the pathophysiology of pain, discuss the contributing factors and the classification of pain, describe the pharmacological and non-pharmacological interventions that are used in pain management, define the role of multimodal analgesia and its impact on pain management, discuss the opioid use emergency and strategies to overcome it, provide an overview on the interdisciplinary approach in pain management. So let's start with like an overall definition of pain. So pain is a unique subjective experience of an individual which cannot be adequately defined, identified, or measured by an observer. It consists of sensory, motivational, affective, and cognitive component. Recently, it was considered as the fifth vital sign. And it is actually the most common reason for physician visit. According to the Institute of Medicine, it states that more than 100 million Americans suffer from chronic pain, and the total direct and indirect cost of pain is around $500 to $600 billion a year. Pain remains till now the most post-discharge complications, accounting for between 24 to 65% of patients experiencing mild to moderate pain. And there was no real improvement in pain management over the last 30 years, and we don't really have the perfect analgesia drug. What is the pathophysiology of pain? We're not going to go in details about it, but we should know that we have the tissue noxious stimuli that will activate pain that often launches a cascade of alternative reaction, which brings both central and peripheral sensitization. Both the peripheral and the central one contribute to hypersensitivity state of injury pain. Usually the peripheral sensitization, it has a lower threshold, while the central one, it brings more hyper-excitability to the uninjured tissue. All these alterations will amplify the severity of pain by elevating the response to noxious stimuli. Pain management should include both the nociception and the central nervous system. So this is a brief review about the anatomy also, where we have different, steps in the anatomy of pain management, from the transduction to transmission of pain, modulation, and then perception. And when we're talking about perception, we're talking about the conscious awareness of pain at the culmination of previous processes in the context of the individual patient experience. How do we classify pain? So based on the International Association for the Study of Pain, classification of pain is as follows. Pain is being described on the basis of its anatomical origin, intensity, or duration and pattern, as well as the cause of pain. We have the nociceptive pain that's usually caused by damage to body tissue, and usually the patient will describe this pain as being sharp, aching, or throbbing pain. We have the neuropathic pain, which affects the somatosensory nervous system. And this is usually more prescribed as burning, tingling, shooting, or stinging pain. And we have the inflammatory pain that's due to increased sensitivity to the inflammatory response associated with tissue damage. And usually we have it's a dull pain that's usually associated sometimes with swelling, hotness, and restlessness to the affected area. In addition, we have the central pain syndrome, which is the amplification of pain signals in the central nervous system. And example to this pain is headache or irritable bowel syndrome. Furthermore, the pain can be classified either as acute pain or chronic pain. The difference between these two classifications is, first, the acute pain, it usually has a short history of onset and does not last longer than days or just weeks, while the chronic pain, it has more of a long history with often poorly defined onset. The duration is unknown, but most of the time it's over 3 months. The associated effect we see, for example, in case of acute pain, if the pain is severe, we see that the patient is having anxiety and sometimes some irritability, while with the chronic pain, we see more symptoms of depression and irritability that are prominent features. And in case of associated features, for example, we see in case of acute pain, the patient can be experiencing tachycardia, hypertension, sweating, and mydriasis, while usually when we go to chronic pain, we see more severe side effects when the patient can be having anorexia, weight loss, insomnia, loss of libido, and other possible side effects. What are the contributing factors that can predict a poor pain control? Younger age, female gender, smokers, patients that already have depression, negative affectivity, education level of the patient, the preoperative pain, the use of preoperative analgesia, surgical factors, for example, the kind of surgery, is it severe surgery, or is it just a mild procedure? And we have also the duration of the surgery that can affect the outcome of the pain. Actually, it was shown that preoperative self-perception susceptibility to addiction was associated with 53% reduction in the rate of opioid cessation after surgery. In addition, 6% of patients actually will continue on the new opioids for 150 days after surgery. And there was like ranking of procedures with like their associated pain score, and the 40 procedure with the highest pain scores, 22 of them were orthopedic or trauma-related procedures. Furthermore, we do have the role of the psychological factors. Actually, in this study that was published in the BMJ in 2017, it showed that greater catastrophic thinking is consistently associated with greater pain intensity. And other studies also showed that increased symptoms of anxiety, depression, alcohol use are also associated with higher pain intensity. In fact, chronic pain in the absence of infection and implants, it's usually correlated with psychological factors. How do we assess pain? It's very important to have a thorough history when we are assessing patients' pain. According to the American Association of Pain, we have to go over all the set of questions, but in brief, we have to first know the pain history, the characteristics of the pain. We should do a physical examination to the patient, and we have to develop the diagnosis and know the etiology behind having this pain. And furthermore, we need to develop a care plan with specific goals and expectations. So these are some of the questions that we have to ask the patient. We have to ask him about the onset and pattern of pain, about the location of the pain, the quality of pain, its intensity, what are the aggravating factors or the relieving factors that help him manage his pain, what were the previous treatment that he used and how did it affect the pain outcome, and what are the barriers to the pain assessment. Some of the tools that are used, we do have, for example, the visual scale, the graphic scale, the functional pain scale. It's very important to use the pain tools before dosing, before starting a medication, and at regular intervals. Usually more frequent pain assessments are required whenever we are adjusting a medication dose, when we are starting a new, when there's a new pain, and for diagnostic or therapeutic procedures and are done. So basically, we have also to ask the patient some question is, for example, in order to understand the range of the pain, we need to ask what is the worst it has been in the past, and we put a specific duration of time. And to understand the nature of the pain, we have to ask what percentage of the time when you are awake have you had pain. Furthermore, we do have a new strategy that was introduced. It's called the clinically aligned pain assessment, or the kappa strategy. It's usually it guides clinical conversation to cover more aspects like a change in pain, the pain control, the functioning and sleep of the patient, in addition to the comfort. The most important thing is to try to target that the patient should not have more or worse than mild pain. The medication effect on pain pathways. So basically, the analgesic medication, they will act by inhibiting ascending pain signals, and they will also work in the periphery or in the central in order to decrease the nociceptive transmission and interpretation of these signals and pain. We should always, encourage the patient whenever we're gonna start any pain regimen. We have to encourage them to set functional goals for themselves in order for us to help monitor the response to the treatment, and at the same time, in order for us to be able to monitor and encourage patient to report side effects. So when we talk about pain management, we talk about the multimodal analgesia. So what is this multimodal analgesia that's been practicing for the last period? So it's basically the use of a variety of analgesic medication and technique that target different mechanisms of action in the peripheral and the central nervous system. So these will have an additive or synergistic effect and more effective pain relief compared with the single modality interventions. This will help us in reducing the reliance on opioids. So it's basically directed towards 4 goals. First, we need to improve, we need to have an improvement in the patient experience through a better pain control. We want a reduction in the post-operative morbidity and mortality. We want a reduction in healthcare costs and decrease in the physician contribution to the global opioid epidemic. Let's start by discussing a little bit the chronic pain management. So we're gonna first go over the chronic pain management, then we're gonna go over the acute pain management. And for the chronic pain management, like we said before, it's usually a pain that lasts beyond the course of healing for more than 3 to 6 months, and it affects the patient daily function and well-being. The risk factors for the chronic pain are divided between non-modifiable and modifiable risk factors. The non-modifiable risk factors include, like, for example, female gender, age over 65, low socioeconomic status, and intense acute pain. While some of the modifiable risk factors include, for example, greater pain related to fear, greater symptoms of anxiety, depression, and post-traumatic stress disorder. The multidisciplinary approach is very crucial and important in case of chronic pain management. In fact, now we hear a lot about, pain clinic or pain management clinic, where we do have a multidisciplinary approach to help take care of the patient. We have the doctor, the physiotherapist, the psychiatrist. So they all work together in order to try to get the best outcome. So basically, the multidisciplinary approach can involve pharmacological treatment. We have intervention, we have the role of physical activity, in addition to psychological support. When we first want to start talking about pain management, about the pharmacological approach. First of all, we have to keep in mind that we do have different classes that are used for chronic pain management. Some of them are approved by the FDA, and we're going to go over the FDA approval in the next slide. But we have to keep in mind that we do have significant variability even within the same class or group of medication. That's why if a patient fails one medication, it doesn't mean that he will not be feeling better if we start him on a different medication in the same class. We have to always keep in mind that we have to change one medication at a time in order for us to really evaluate the effect of this medication or of this change that we just did. And we should always go slow. When we go slow, sometimes this can create some frustration from the patient end because the patient is expecting an effect and they want to feel better right away. But this is our role, to provide education and to inform the patient is by going slow and starting low. We are trying to avoid having, the possible side effects. Now, if we want to talk about the classes, first we have a pregabalin. Actually, we have a pregabalin and gabapentin that we can cover in this section. We have to always start low and titrate slow over a few weeks. We have to inform the patient that it might need 2 to 4 weeks to determine the efficacy of the medication. With this class, we have to be cautious about the risk of abuse and misuse. And we have to be cautious when combining this medication with other CNS depressant. And that's why we have to be extra cautious in case of elderly people, because they're going to be at increased risk of fall, for example, with this medication. Also, this medication can lead to increase edema and to increase in the body weight. Furthermore, for this medication, we have also to be careful in case of patients with decreased renal clearance. For the TCA, they are more associated with side effects, of course. So for them, we have to also start low and titrate slow. And they do have some drug-drug interactions, so we have to be careful in case of patients on other medications. They have increased anticholinergic side effect, and in case the patient is to be started on this medication, sometimes, and depending on the dose, we prefer to have a baseline EKG, because we know that this medication can increase heart rate, cause QT prolongation, and also we have to be careful in case of medication on other medication, because we are at increased risk of serotonin syndrome. For the SNRI, these medication also can take weeks to onset for pain relief. But usually, like, we need lower doses than the one that are used for the treatment. And they do have like lower side effect compared with TCA medication. We have to be careful in case of patients that have uncontrolled blood pressure. And we have to also be careful in case of patients that have narrow angle glaucoma because they can worsen it. Now, for the muscle relaxant, we're gonna like go more over this category of medication later throughout the presentation, but just we have to keep in mind that it does not directly work on pain. They are not really pain medication, and we don't have enough literature to support their efficacy and their use in case of chronic pain management. So like we said before, this table, it shows which of the medication are FDA approved for the use of chronic pain medication, pain management, and which one are not. So we see that we have the duloxetine, that is the only one with FDA approval for 3 indications for neuropathic pain, fibromyalgia, and nociceptive pain. Milnacipran is only approved for fibromyalgia, and all other medication, they don't have FDA approval for use in chronic pain management. Now, it's very important with these medication because they are associated with like some side effects. So us as healthcare professionals, we should be able to know the side effects and try to help them overcome the side effect. One of the side effects that's very reported is nausea. So in this case, what we can do is, like we said before, to always start low, titrate slow. Usually these symptoms will go within a week, within like week times, like a week time frame. But we have also to ask the patient whenever possible to take this medication on full stomach and to schedule them, if possible, for bedtime. Another side effect that it's usually also seen is like the sexual dysfunction that is associated with this medication, and this lead to it's associated with the highest rate of discontinuation and patient dissatisfaction, and that's why it's very important to be open with the patient and inform him about these possible side effects. For weight gain, we need to be proactive. We have to provide education to the patient about weight management. We have to encourage him to exercise, reduce his caloric intake, and to have some baseline measurement so we can further monitor this weight gain. Usually the weight gain is more often seen with the TCAs. For sleep disturbances, now it depends on the medication and it depends on what kind of sleep disturbance the patient is having. If the patient is having more like insomnia, then we can give him some medication that can make him a little bit more sleepy, and vice versa. If the patient is having somnolence, then we can give medication that can make him a little bit, that has like an activating effect. And we have to also encourage the patient to have good sleep hygiene. For the agitation or worsening, also we have to go by the lower dose if possible. It's like sometimes we can add a small course of benzodiazepine to help with this, but actually it's not very recommended. And if we have to do it, then we have to limit it to 2 weeks to avoid dependence. We're gonna start with our first case for today. So we have KM, who's a 55 years old male. He was admitted to the hospital for a procedure. The patient was on labetalol, gabapentin, and rosuvastatin for the last 6 months. Post-op, the patient remained NPO for 3 days and he was not taking his medications. On day 2, the patient started experiencing anxiety, sweating, palpitation, and fatigue. And on day 3, he was restless, disoriented, confused, and agitated. All medications were restarted on the morning of day 4, and the patient's confusion and agitation improved that evening. The next morning, the patient was calm, alert, and cooperative. So what do you think was or is the leading cause behind the patient's status?
Feel free to type your answers into the chat box.
Okay. So we need to talk about, with this medication, we need to talk about withdrawal. These medications, they carry a risk of withdrawal if stopped abruptly. Some of the symptoms of withdrawal are nausea, dizziness, insomnia, headache, anxiety, fatigue, irritability, and they prescribe it as some electric feeling, you know, in neck and head. It's like a shock-like sensation. So what should we do? We have to, as a healthcare professional, we have to implement strategies to reduce the risk of this withdrawal symptoms. First, we have to discuss these symptoms with the patient when we initiate therapy. The patient should not stop the treatment abruptly. Like we said, it's very important to highlight this point. The tapering, whenever possible, should be done over weeks, not only days. And if we do like tapering, that's slow tapering, but we see that the patient is still having these symptoms, then we have to change the patient to long-acting format. So if we go to this patient, we see that the patient was on gabapentin, and the gabapentin was stopped for 3 days. Actually, gabapentin withdrawal symptoms can start like 12 hours after stopping the medication. And because he's been on this medication for a long period of time, and for like 3 days he did not take the medication, he actually started developing signs and symptoms of withdrawal. And unfortunately, sometimes when the patient is admitted to, you know, to hospitals, he's an inpatient, like if he doesn't like bring his medication with him, or he doesn't disclose all the medication he's on at home, and he's here for a few days without taking the medication, we can notice these side effects. And that's why we should be very aware and to always take a very thorough medical history and do a very thorough medication reconciliation upon admission of the patient. Opioids. So also opioids are related to are involved, of course, in the chronic pain management. The first thing that we need to talk about is actually opioid-induced hyperplasia. What's opioid-induced hyperplasia? When the patient takes actually opioids for a long period of time, we start having sensitization caused by the exposure to opioids. And in this case, patient who's receiving the opioids now become more sensitive to pain sensation. So we have to keep this in mind when we are giving opioids for a prolonged period of time. And it's no secret that we have a huge epidemic of opioids misuse and abuse happening in the US for like a long period of time. And the CDC officially published a guideline for prescribing opioids for chronic pain in March of 2016. And it actually provided 12 major recommendations for the safe and effective use of opioids in the treatment of patients with chronic pain. I'm not going to go into details, but what we have to keep in mind is first, whenever possible, when we are starting a patient on opioid regimen, always try the immediate release formulation, at least for 1 week before switching the patient to long acting. We have to always get the lowest effective dose that should be prescribed. Again, start low and go slow. In case we have a patient with acute pain and you want to give him opioids, don't give him more than a 3 days supply, no more than 3 days supply. And the benefits and the risk of the treatment should be reassessed within 1 to 4 weeks. If the therapy is to be continued, then in this case, the reevaluation should happen at least every 3 months. We have to always also assess the patient for risk of overdose, and that's why we should evaluate if the patient should receive also a prescription for naloxone. When possible, we can have a urine drug testing before starting the opioids, you know, and we have the PDMP. So the PDMP is a prescription drug monitoring programs, and this is a very helpful program that I used to use like personally in the US. So basically this programs, it allows you to access the patient information because the patient can go to different pharmacies and to see different doctors to try to get like different prescription of controlled drugs. And with this program, you can log in with the patient ID or driver license, and it will show you the history of medication that he picked up from any pharmacy in the US. And then it will be up to you to whether accept dispensing the medication or refusing giving the medication to the patient. And this also will decrease the risk of misuse and abuse of opioids medication. Whenever possible, we should avoid the use of benzodiazepine at the same time with opioid. And we always have to establish goals for the treatment. And it's always, much preferred to start with a non-pharmacological and non-opioid regimen. And we also have to discuss the risk and actual benefits with the patient before starting the therapy. When it comes to chronic pain management, also we have interventions. So this as the part of the multimodal analgesia. So interventions include steroid injection, nerve treatment, sympathetic and parasympathetic blockade, implantable devices that can have also medication pump in them that can give opioids, clonidine, or local anesthetic. And we also can have minimally invasive spine and joint procedures. The limitation of these interventions usually are infection, bleeding, nerve damage, or possible injury. Physical therapy is also a crucial component. Actually, around 50% of the patient, they show elevated fear of physical activity when they are in pain. And that's why, as a physiotherapist, the physiotherapist should work on strategy to strengthen the musculoskeletal of the affected area and increase coordination. He should work on improving tissue tolerance. Most importantly, he should provide education, address the fear and belief that the exercise is harmful, present active intervention, and use a behavioral therapy approach to help restore physical activities and improve the quality of life, and provide guidance for self-management and pain coping tools. Psychological support and well-being, also a crucial factor like we discussed before. It's a fundamental aspect of pain management. Some studies showed that the variation in pain intensity is more correlated with measures of psychological aspect than by measure of pathophysiology. There is an overlap between the neural pathways involving pain and the one involving anxiety and depression, and thus the correlation between them. And chronic pain may cause mood disorders leading to worsening in pain treatment outcome. Now, moving to acute pain.
Dr. Nouhad,
yes.
just to see if we could pause for a second here and ask if there are any questions that we have from the audience. So open up the floor to questions. If you can type them into the chat for us. But while our participants are thinking of questions, maybe I could ask just a couple of questions from your experience of managing chronic pain for patients. I'm wondering, from your perspective, what do you think is the most challenging aspect of chronic pain management from your practice?
The most challenging aspect is actually to get, I feel like the most challenging aspect is to provide the most optimal medication regimen to the patient. There's always challenges with these medications, especially with the side effect profile. We always try to tailor, the regimen based on the patient history, condition, past medication history. But there's always a challenge with this kind of medication. Challenge with compliance on the long term. Sometimes the side effect can affect patient compliance, and although it was, the medication was helping the patient, but still sometimes we really needed to change the therapy due to side effects and then go back from point zero, And another thing is to convince the patient to do the physiotherapy. This is also another challenging point that we find most of the time. Especially that some of the patients with the chronic pain management, they are elderly, and to convince them to exercise and do physical activity, it's a little bit challenging.
Most definitely, of course. Go ahead, Dr. Hazem.
I think this is a very interesting stop here, and I have another question for Dr. Nouhad. And again, since you're working with Aspen Heart Hospital, How was your experience with sports medicine, and how do you see really sportsmen, if you will, benefiting from physiotherapy versus pain medications? And do they typically wean off on pain medication after a while, or is that sometimes also is a stressing problem for sportsmen as well?
This is an excellent question, Dr. Hazem, but we keep it for later because we have the whole slides about it.
Oh, okay.
Yeah, we're going to discuss it in details later about athletes being in like an Aspetar athletic hospital. So we have slides and the case about this too.
Perfect. That's great. Dr. Nouhad, we do have one question from the audience, and the question is, what are the complications when opioids are taken with benzodiazepines together? What sort of things should they watch out for?
Yeah, so they have to watch out for like CNS, like excess CNS depression, which can cause like respiratory suppression too, which can be like very harmful for the patient when combined together. So more CNS depressant side effects that can also affect the respiratory system and can, at some point, if in overdose, can lead to death actually.
Great, thank you very much. One last question, perhaps, before we continue into the acute pain. You had mentioned before that there was some difficulty in managing patient expectations and how you are, I guess, setting goals of therapy. Patients want zero pain. That would be the ultimate goal.
Yeah.
How do you help manage some of those expectations of how well medications might be able to work for them?
Yeah, that's why we have like, I feel like the best approach is to like have like open discussion and education to the patient, and always set the expectation clear. Like it's like baby steps. So when the patient comes, he's expecting, like we said, to have like a medication and next day, like to feel like much better and the pain is gone. So when you set expectation to these patients and provide them education and explain the effect and mechanism of this medication, I mean, of course, very in a simple terminology, not complicated way at all, and to inform them that, pain is a very complex thing, and we cannot tell about, the outcome of this medication before we start it. And that's why we talk in the beginning that we have to encourage the people to have a functional goal and to actually monitor themselves and come back to us. So for me, the most crucial thing is education and communication with the patient. We should communicate with our patient and explain stuff to them. Sometimes listen to them all the time, listen, explain, educate, and monitor and follow up. And I think this is the best way to approach them, because when they come, they are like psychologically not feeling well. Sometimes they're miserable, they're tired from this pain, right? And they have high expectation, but you have to like put like the expectation real, keep them real.
That's great. I think that's really important to really solidify in our minds of being patient specific, and that there should be functional goals for the patients, especially for chronic pain. That's great. Thank you very much. Let's continue on into acute pain. And if anyone has any further questions, please feel free to write them in the chat and we'll see if we can get to them later on.
Awesome. Thank you. I'm sorry, but okay. Just let me move this. Okay. So like we said before, that opioids, they carry the risk of misuse, and there was some studies about the use of opioid in surgery, because acute pain, surgical pain, is a part of the acute pain, right? So the patient that take opioids before surgery, they are at higher risk of opioids-related adverse event, especially respiratory depression and sedation. It's interesting that like some statistics from the US showed in a recent survey that patients receiving chronic opioid, of patients receiving chronic opioid therapy, 27% were first started on opioid after surgery. And patients who consume more opioids usually communicate greater pain intensity and less satisfaction with pain control. Now, why is it important to save on prescribing opioids to the patient and reduce it? According to the Center for Disease Control and Prevention, if 100 people on a hospital service are discharged with opioid, the following result will occur. Can you imagine? For every 100, you will have one who will become a heroin addict. You will have one who will die of opioid misuse. You have one who will engage in opioid diversion. That's why we have to limit our daily dose of morphine. We have to limit on-day supply for acute management, like we said before, for treatment-naive patients. We have to develop pain stewardship. Actually, some studies showed that the institution and the organization that have pain stewardship, or they have specific guidelines and protocol for pain management that are very well monitored and implemented in their organization. Organizations that have in the pre-admission clinic that do education to the patient and inform them about the risk, of opioids and the risk and benefits of opioids. It was shown that these actually organizations, they have a much lower post-op opioids use, and at the same time, they have actually greater patient satisfaction. So we have to all work on the development of these kind of stewardships, guideline, protocol, make sure to implement them and monitor them at our organization. Like we said before, lowest dose, avoid combining with benzodiazepine. We have a higher risk of overdose and side effects. And like we said before, we have to implement guidelines. Very quickly, some of the risk factors that are associated with prolonged opioid use, socioeconomic status, clinical status, like we said before, for major surgeries, there's more incidence of pain, and we have high dose of opioids that are usually used for inpatient management. Usually, we have in some organization, lack of the multimodal pain management, which lead to more prescription of opioids. And we have also medication formulation, where sometimes we have patients that are started on extended release formulation of opioids. Now, as a clinical pharmacist, for example, we're gonna discuss quickly the second case. We have KD who had a major surgery, and during his inpatient stay, he was maintained on PCA morphine, and the patient had a total dose of 120 milligrams of morphine a day. And the physician wanted to switch the patient to PO oxycodone. And as a clinical pharmacist, you were asked, for example, to do the dose calculation for oxycodone. While you are thinking about the math, we're gonna do just a little bit the PCA, just very briefly. So PCA, it stands for patient-controlled analgesia, where the patient has own control on the pain relief. So whenever the patient is in pain, then he can click, press the button, and a small dose of morphine, fentanyl, what have you, will be injected into his veins. The advantage is the patient will feel when he self-administer, he feels he's in control of his pain. And we know this actually, it will lead to less amount of a drug being required. But we have to be careful, sometimes it's not very practical in patients that are critically ill, patients that have learning difficulties, and also patients that are already heavy opioid users and have a possible risk of abuse and misuse. Now we're gonna go back to the case and see how we do the calculation. I'm not gonna go in details over the calculations, but what we have to keep in mind is to take few important messages. The first step that we have to always do is to calculate the switch from the IV morphine to the PO morphine dose. And there are tables, these equi-analgesic table conversion that can be used to do all these maths. So first of all, we have to calculate the PO morphine dose. After we calculate the oral morphine dose, we have to switch it to oxycodone. And like we see in this table, in order to switch from morphine to oxycodone, the factor is 1.5, which means 300 milligrams of morphine is equivalent to 200 milligrams of oxycodone. A very crucial step is to calculate for incomplete cross tolerance. Because the patient has been on the other medication, when we start him on the second medication, there is risk of more side effects and more overdose. That's why the dose that we calculated, which is 200 milligram, should be reduced by 30 to 50%. And this is, please, very important to always remember. In this case, now our oxycodone dose is between 100 to 140. The next step is to always check the availability. What are the available formulation of this medication at your institution or in community pharmacies? For oxycodone is available as 60 milligram. So we can take 120 milligram, this is going to be 60 milligram PO BID, right? Because the range, as we said before, is between 100 and 140. So the patient will be maintained in this case on 60 milligram PO BID of extended release oxycodone. Another step that we should not forget is to calculate for the possibility of a breakthrough pain, right? So breakthrough pain, usually we do 10 to 20% of the dose that we calculated, which is like 120 milligram. And this dose, or this percentage, should be reduced in case of elderly patients. Usually it's like around 5%. After we calculate the immediate release oxycodone dose, then now we have the patient stabilized on the long-acting formulation, and we have the short-acting formulation in case of breakthrough pain. After we are done with the calculation and we start the patient on the treatment regimen, we have to taper the patients, and we have to monitor his response or her response to the pain medication we just provided. When we talk about opioid tolerant patients, we have limited studies about these patients. We have to keep in mind a couple of things, that we do have a cross tolerance, so which makes it more difficult to find a pain medication, and it's more difficult to control the pain. Patients, like we said before, they will have increased sensitivity to pain. Tramadol also, like, it carries a risk of abuse. It's not like it's not gonna cause abuse. And we also have to always provide education and discuss the baseline pain medication with the patient, and we should always have adequate calculation of the medication dose. Our third case for today is we have DK, who is a 67-year-old woman. She presents to your community pharmacy with a prescription for ibuprofen 800 milligrams 3 times a day, and the prescription for acetaminophen or Tylenol 1 gram or 1000 milligram Q4 hours, both for 3 weeks. She explained that she had a mild ankle sprain 2 days ago, and upon reviewing her patient profile, you notice that her current medications include metoprolol, lisinopril, and atorvastatin. You ask her about her past medical history, and you discover that she experienced an MI about 3 years ago, and she's also on a daily low dose of aspirin. As a pharmacist or as a doctor, what will you recommend? Will you dispense the medication or not? So while we are thinking about the patient case, let's do a brief overview about paracetamol and NSAIDs, paracetamol or acetaminophen, used in case of analgesia. First of all, paracetamol, it's mainly used for mild pain. It shows that, it does actually reduce the cumulative 24-hour morphine consumption in major surgeries. There was no advantage when comparing the IV to PO formulation, so whenever the patient can tolerate the PO, we need to switch them. According to the FDA, paracetamol overdose is the leading cause to acute liver failure in the USA. And when given a therapeutic dose, there is no risk of hepatotoxicity. Although here it says like usually it's less than 4 grams, but the manufacturer recommendation is usually less than 3.5 or 3 grams a day. And we have to always be cautious in case of patient on warfarin. For NSAIDs, the first thing is like we do have a ceiling effect with NSAIDs, which means lower dose can be as effective as high doses, but with less side effects. So whenever we are prescribing, we have to keep this in mind. And higher doses are usually more used in case of inflammation. This is like here, like, for like the NSAIDs, because they are very commonly used, we have to keep a few things in mind. When to avoid them? We should avoid them in patients with high cardiovascular risk, patients that have treatment-resistant hypertension, patients with severe chronic kidney disease, and patients with moderate chronic kidney disease that are on ACE inhibitors, ARBs, or diuretic. Before initiating the therapy, always measure the blood pressure, double check, screen, patient at risk for any unrecognized chronic kidney failure, like for example, or disease. If we have diabetic patient, hypertensive patient, patient above 80, patient with heart failure, ischemic event, and always investigate unexplained iron deficiency anemia. When it comes to choice of NSAID, if you have a patient with high blood pressure, but it's controlled, it's better to have him on an naproxen or celecoxib rather than having ibuprofen because it was associated with more increase in blood pressure. If the patient is at higher risk and he's already on ARBs or ACE inhibitors and he needs to be started on NSAIDs for a long time, then maybe we can consider either increasing the dose of the ARBs or ACE inhibitors or to add on another therapy. In case of cardiovascular, also naproxen and celecoxib were the treatment of choice. In case of a patient with GI problems, NSAIDs, if he has NSAID dyspepsia, so we can use the PPI. If the patient has moderate risk of peptic ulcer disease, we either go for NSAID plus PPI or COX-2 inhibitors alone. In patients with high risk, of PUD, then we can do COX-2 inhibitors plus a PPI. If we have unexplained anemia, it's better to refer the patient to see a gastroenterologist, and if needed, we can start him on celecoxib. For the monitoring, we have to monitor, as we said, the blood pressure. It worsens usually after 4 to 8 weeks. And if we don't have existing, history of blood pressure, we can monitor it after 4 weeks from initiating therapy. In case of patient with existing blood pressure, of course, the monitoring should be more often. And we have to always check for edema and body weight with this medication. And with patient with a pre-existing chronic kidney failure, we have to check 1 week after initiating the NSAIDs and periodically thereafter. Another thing that we have to keep in mind with NSAID is this controversy we have about the use of NSAIDs in case of orthopedic surgeries and their effect on bone healing. You see more and more doctors, shifting and moving from the use of NSAIDs into using, opioids or other medication because they are worried that, the NSAIDs will affect or impact the outcome of the orthopedic surgery. Actually, studies are very the outcome of the studies are very different. Some studies does not show any effect. Some studies shows more effect if the patient has some of the risk factors. Some of the risk factors include female gender, use of tobacco, alcohol use, or if we have if the patient will take NSAID with high doses for a long period of time, which is more than 2 weeks. We should not just withhold this medication for all patients. We have to always consider it on an individual basis and keep in mind that even opioids, sometimes they affect bone healing. So we have to always weigh the risk versus benefits. Going back to our patient, so for our patient, we have to recommend for her the RICE, which is rest, ice compression, and elevation. We have to encourage the patient to exercise. And when we evaluate the NSAID that she was on, first of all, they gave her NSAID 800 milligrams 3 times a day for 3 weeks, which is a high dose. And it's actually more than the required duration for this indication, which should be around 2 weeks. The patient has a moderate risk of peptic ulcer disease because she's on aspirin and her age is above 65. And the patient is on ACE inhibitors and has a history of MI. So in this case, we can do 2 choices for the patient. We either can start her on Celebrex, or we should call the doctor to switch the prescription to Celebrex because Brufen is not the recommended regimen in this case. Celebrex POBID. Or if we want, we can give her naproxen, but in this case, she will have to also be on a PPI. The duration should not exceed 2 weeks in this case. And for the paracetamol, the issue, or the Tylenol, the issue is Sometimes because it's an OTC, we say 1 to 2 every 4 to 6 hours. But in this case, the patient is taking 1,000 milligram Q4 hours, so she's taking around 6,000 milligram a day. So it's very important to educate the patient to say take it every 4 to 6 hours as needed and do not exceed 4 gram a day. Sometimes because it's an over-the-counter medication, this information can be easily missed. The same multimodal and
Dr. Nouhad,
yeah.
just one question about the case, just before we carry
Yeah.
forward. What is your opinion on the role of topical NSAIDs for things like the mild ankle sprains? Do you think that there's a role for these?
Yeah, definitely. They do help, yes. They can be used sometimes. Now, it depends like on the level of pain and if we are suspecting more inflammation and we would like to go with like a low dose of like, you know, like NSAIDs, but they definitely help, yes. And they can be used.
Great. And there was one question from the audience regarding the use of statins, and I guess more specifically around statin-related myalgias. And the question was around when patients experience intermittent muscular pain due to statins, is there something that they could do to manage these muscle pains? Should they take medication or should perhaps they adjust the statin or the statin dose?
Actually, like if they have these side effects, I will recommend them to go see their doctor. Never treat the side effect of a medication. Rather than go see a doctor, they will do the adequate blood test and monitoring, and maybe the patient should be changed to a different statins or stop the statins altogether. I will never recommend the patient himself to change or to like stop, change, or treat side effect of any medication without consulting with his doctor.
I think that's a very good point. And from my practice in the heart failure clinic, we see statin myalgias quite often. And so, you know, making sure that the appropriate blood tests are taken and most commonly either lowering the dose or perhaps changing the type of statin could even resolve the issue to alternative high-intensity statins. There is one other question, from the audience regarding what type of exercise that could this patient do. So for example, that would be a patient with the mild ankle sprain. What type of exercises would be recommended and at what frequency?
Well, this is more for like a physiotherapist. I'm not expert by all means, you know, when it comes to the exercise and what kind of exercise it's recommended for these patients. Like, I'm not gonna step in, you know, their field. I am not an expert, you know. I know that exercise is like basically recommended. It's like encourage the patient to exercise and not to be mobile. But what exactly that kind of exercise, I am not sure, to be honest.
May I ask
Completely
one
fair.
more question?
Yeah.
I'm sorry, Dr. Nouhad, but it's an exciting topic, so we have more questions. Now, let's say in this case, if we have this patient with chronic kidney disease or advanced kidney disease, what would be the recommendation regarding pain medication if they're not eligible for NSAID?
If they are not eligible for NSAIDs?
Yes, due to their advanced renal disease.
I think in this case, doctor, we can always start them on like the Tylenol, and then we can encourage, like we said, like non-pharmacological treatment. Like the non-pharmacological approach, actually, they can have like very like, you know, very good outcome with these like these situations. So we can put him on paracetamol and then like, encourage him to do the non-pharmacological. And then we ask him like to come back if this doesn't work. But I won't give them, of course, NSAIDs. So we'll start them on these medication. And we also have these topical analgesic that can be used, you know, that the topical one. Then we can also recommend one of these topical medication.
All right, thank you.
Great. Thanks very much for answering our questions, Dr. Nouhad. And again, if there are any additional questions, please type them into the chat and we'll get to them towards the end of our presentation today.
Awesome. Can I continue?
Yes, please.
Awesome. So we see here like other medication that are usually used like as a part of the surgical pain management. Again, I'm not gonna go in like great details over these medication, just we have like few points that I would like to highlight. First of all, we have the glucocorticoids that are sometimes used, pre-op, and they do reduce, risk of nausea, vomiting. They reduce the need for opioid post-op, but they are not recommended in case of immunocompromised patient and patient with uncontrolled diabetes. And this question we get it a lot sometimes here, like if the patient is diabetic, should I like not give glucocorticoid pre-op? Actually, if the patient, his diabetes is very well controlled, his blood sugar is good, and his HbA1c is fine, then it's okay to give one dose of glucocorticoids pre-op, but we have to monitor him post-op because sometimes the effect on the blood sugar can be a little bit delayed. So we just need some monitoring post-op, but if he's well controlled, it should be fine. For the magnesium, it does have some opioid sparing effect. We don't have lots of studies about it, but it's used sometimes to extend the effect of the sensory block with spinal anesthesia. Alpha-2 agonist can be used also sometimes. They can cause sedation and hypotension, so we should be careful with this. For the ketamine, the studies are like, we do have like different type of studies outcome on this. It can have benefits, but we see that the benefits are usually offset by the dose-dependent side effect. We have patients that can have side effects with psychomotor effects, and that's why we should be very careful in patients that have existing history of schizophrenia, and also in patients with cardiac disease because it can lead to tachycardia. The gabapentinoid, we already spoke about gabapentin before. The studies for the use of gabapentin, you see like different outcomes. Some studies shows it has like good effect, a post-op, good effect post-op, but some other studies showed that these results were not really statistically significant. Another medication that we can use is the lidocaine. For the lidocaine, we have to be careful, especially in patients that have a decrease, not hepatic issues, but decrease in the hepatic blood flow, because we should be careful about it. And also, like, we have to keep in mind that the lidocaine metabolite can also sometimes increase risk of seizure in some patients. When we talk about local and regional anesthesia, like, it has lots of advantages. It's basically it decreases respiratory complications, thrombolytic effects, surgical site infection, decrease, for example, we have less nausea, we have better post-op pain, we have reduction in the intraoperative blood loss, we have reduction in the inflammatory reaction, and usually it's associated with an accelerated resumption of physical activity, fewer sleep disturbances, and higher patient satisfaction. Nerve block is also like widely used like in the practice. The challenges with this is sometimes if we have by mistake intravascular injection of these while doing the nerve block, we have some risk of infection. We have the risk of the masking symptoms of compartment syndrome, and concern about some rebound pain that's shown that patient will have this intense pain after 12 to 24 hours from having these nerve blocks. Again, the non-pharmacological treatment are very important in this case, like with chronic pain, physiotherapy, massage, some meditation. They can all be helpful in this case. Very quickly about the use of muscle relaxant. Like we said before, like medication, they are tend to be more frequently used than necessary. We have the antispastic and antispasmodic medication. We have to be very careful when we dispense these medications. Because they are associated with lots of side effects and sometimes drug-drug interaction. We should be very careful in case of elderly, because especially, patient over 65, because they do have anticholinergic side effects. They can lead to sedation and increased risk of falls and fracture in this category of patient. We always recommend short-term use, and we have to always use them based on the individual factors, including duration, severity of symptoms, prior response to medication, potential effects, desired benefit, and comorbid condition and cost. Like we see, like lots of them, they are associated with like serious side effects. We have to always like provide adequate education and counseling to the patient. And we have diazepam and tizanidine that are considered both, you know, antispastic and antispasmodic medications. Our last case for today is about CK, who's a professional athlete that's praying for the national basketball team. During the competition, he visited his doctor complaining about pain from musculoskeletal injury. The physician administered triamcinolone acetonide 60 milligram intramuscular to this player, and a few days later, the athlete was banned from competition. What do you think happened in this case? And we brought this case specifically because now, like Qatar, we have lots of sporting events happening all the time. We have the Arab Cup, the FIFA Arab Cup, we have the World Cup coming in 2022, and we are all exposed to maybe having an athlete coming over to our institution or to a community pharmacy, and that's why I thought about bringing this case. So let's talk a little bit about, you know, pain management in elite athletes. We do have like different studies about this topic, and we acknowledge that we do have gaps in knowledge about pain management in elite athletes. Lots of issues to consider and lots of points to think about, like we have the return to practice, we have the WADA prohibited list, we're going to talk more about it. We have the stigma, like sometimes the athlete will hide his pain, so he will be like allowed, or he will be able to go back to practicing and go back to competition. We have to know more about the importance of exercise. We should have more involvement and familiarity from sports medicine doctor about anti-doping issue and some ethical issues. And actually in studies, the athletes, they said that they want to be more involved in the decision making and to know more about it. So we do need rigorous prospective studies of various pain management strategies in elite athletes to enable a shift from a consensus-based recommendation to an evidence-based recommendation. So let's go back to our friend athletes and see what happened with him. So we do have WADA. WADA stands for the World Anti-Doping Agency. And we have lots of medication that are on the WADA list of prohibited items, and steroids happen to be one of them. We have to be very careful when we consider this, because some of these medication to be allowed or not allowed depend on the type of sports. Sometimes depends on if the athlete is in competition or outside of the competition, and it can actually lead to banning a patient from competition, like what happened with our athletes. Sometimes within the same group, we do have some administration routes that are okay, like that are allowed. For example, in this case, in case of steroids, the inhalation are okay, they're fine. Intra-articular injection of steroids is okay as of today, but starting in January 2022, it's going to become on the prohibited list, for example. That's why we have to always keep an eye on this list. But other administration like, IM, IV, and PO are prohibited. In this case, what the doctor did is like he provided the patient with IM injection of steroids while in competition, and that led to his ban. That's why we as healthcare professionals, we should be very aware about this. We have to always keep in mind the washout period of each medication that we give to know if it's gonna basically affect the patient. Like if the patients come today and he has a competition, let's say in 2 months, can I give him this injection? It depends on the washout period of each medication. Like and also the physician should always consider other treatment modalities that does not affect the athlete's ability to compete. And one crucial thing that has to be provided to the patient is a TUE. And TUE stands for Treatment Justification Exemption. This form is usually submitted by the doctor. It's filled and submitted by the doctor if he thinks this medication is the best treatment for the patient. So if the patient receive or the athlete receive this TUE, even while in competition, at least he has the explanation as of why he needed this medication. And actually the TUE is a very long form. It requires lots of information. But again, just all of us as a healthcare professional, we should be very aware of this. We have to take good care of our athletes and make sure that they don't get banned because of taking some medication or supplement without knowing its effect and without knowing that it's actually on the WADA prohibited list of medications. Any questions regarding this case? Okay, so
none in the chat so far.
All right, awesome. So basically, like we are almost done with our presentation. Just if you want to see what's happening, what is like what's new in the chronic pain pathophysiology, like you know, they are like working on more like understanding the pathophysiology of pain. It's a work in progress. We are still working on it. They are working more on creating opportunities for targeted therapy that may prove to be effective intervention. And, you know, they want to work on more novel targets for targeted therapy to prevent, treat, and modify the disease course of acute, chronic, and neuropathic pain. Currently, most of our pain management techniques, they do not target this pathway directly, but there is promising evidence to suggest that the field is advancing toward available therapies in the near future. What should we do as a healthcare professional? So let's always adapt a multimodal approach. Let's always limit the use of opioids, promote early mobilization and early resumption of oral intake. Always create a patient-centered, individually tailored pain medication regimen that include a discussion of plans, goals, treatment options. We have to provide education to foster realistic pain expectation and spread awareness pre-op or pre-starting a medication regimen. We have to always get a thorough patient history of pain to know that the history of use disorder, previous success and failure, psychiatric and medical condition. We have to implement monitoring and comprehensive pain assessment at admission and reassessment during hospitalization and following discharge to guide the treatment decision. And we have to work on education, on research, and on quality improvement. And we have like lots of studies that are published that show that the involvement of healthcare professional and the enhanced care coordination between surgeon and other, for example, physician and healthcare professional could allow earlier identification of patient at risk of new persistent opioid, and actually it can also lead to a reduction in the overall use of opioids following like different surgeries and in general. Thank you.
Great. Thank you very much, Dr. Nouhad, for sharing your expertise and your experience in pain management with us. I certainly learned a lot, and it certainly reminded me of some important management points to be sure to consider as well. Specifically, I really liked your comments, or really relate to those comments about managing patient expectations and how important that is. That you need some patience to be able to find the right pain regimen, especially for those who have chronic pain, and that importance of the multimodal approaches, using physiotherapy or cognitive therapy in helping manage pain, I guess, for those more complex chronic pain cases. So we'd like to open the floor to ask if there are any questions at this point in time. So we'll wait just a minute or two for the audience to type any questions that they have in. In the meantime, Dr. Nouhad, I've got just a couple of questions for you. The first is you presented a great deal of evidence, and some of which is really important, and I think perhaps even practice changing. How do you stay up to date with pain therapy in your practice?
So,
are there specific resources that you go to or things that you sign up for that sort of help inform you on a day-to-day?
Well, like actually what we are currently working here on developing our own pain protocol, pain management protocol at Aspetar. So this so we've been like, we always are looking for the most up-to-date studies, like new guidelines, new protocols that are like released. And this is how we keep up to date, you know, and we always try, like every time we do have CPD activity, like whether it's accredited or not, to always have like the pain management as one of the topics to keep everyone alert about the new development, new recommendation in this field.
Great, yeah, it's so important to stay up to date, and also so difficult to stay up to date as well with how much information comes out and how quickly
Yeah,
it
definitely,
exists.
definitely.
We do have one question from the audience from Zara, who asks, in regards to pain management, what is the role of alternative and complementary medicine?
So actually, like there are like some studies that show that these alternative medicine, they can be helpful too in treatment of in the management of pain. They can be helpful, definitely.
And I think probably comes down to that whole patient-specific approach. And if a
Exactly.
patient is willing to try it, sure, try it out,
Yeah.
but also have some clear monitoring points, right? Of if it's not working, well, then we can clearly say it's not working and perhaps something could be stopped. If it is working and is okay and
Continue.
safe, then,
Yep.
you know, something reasonable to continue. That's great.
Definitely.
All right. Many thank yous that are coming in from the audience. One, I guess, last question for you, Dr. Nouhad, is within your experience, since we use medication so often to treat pain as sort of a mainstay of it, what sort of key side effects or do you come across the most often, and what should our participants really be on the lookout for?
You know, like here, because we are like mainly like in our hospital, like as you know, we are orthopedic, you know, hospital. So most of my patients are being discharged on pain management post-op, you know, after the surgery. And we have also like patient on chronic pain. So basically, like our regimen for most of our patients, we try to most of them, they are on a combination of like Tylenol and like an NSAID whenever recommended for a short period of time. We always give it for less than 2 weeks for sure. Opioids are only used if needed, you know, in case the patient had like, depending on the severity of pain. So we, like the main side effect that we see, we don't have lots of side effects to be honest, because they are more on the shorter period of time. They can like come back saying that they had some GI side effects using the NSAID. Some of them, they insist on leaving with a PPI, which is a completely different story, but you know, they have previous, you know, experience with the NSAIDs and they refuse to leave without having a PPI. And this is another, you know, role for education. But these are the main side effects. Now, if we are talking about other patient who comes with a chronic pain medication, chronic pain, and they are on like amitriptyline and these kind of medication, then we see in this case more side effects related to specifically this class of medication. But for our post-op patient, usually it's like just like some acetaminophen and just some NSAIDs. That's it.
Great. So short-term stuff, probably not too often, but for some of the longer-term ones, perhaps be on the lookout for, but hopefully a little bit less common than we may
That's
expect.
why, exactly, it's more for our patients that come to the pain clinic and have like more of a chronic pain, you know, and we see more side effect with this group of patients, more than our like inpatient.
Okay, great. One additional question from the audience who asks, how do we avoid the expected withdrawal effects of opioids?
So usually like what we do is like, you know, there are some new like medication that can be used in this case, you know, that can like, first of all, we have to taper, we have to go slow. We have to taper the medication slowly. Sometimes we have to introduce other like alternative medication. And we have like partially agonist, you know, partially agonist opioid medication that are combined, for example, with naloxone that can be used for these patients with dependence on opioids, and it helps them to taper down their opioids abuse or overuse.
Okay, so taper down slowly over a period of time. Don't rush things. Be on the lookout for those withdrawal effects, and there might be some alternatives that might be available to help ease some of that as well.
Definitely.
Okay, fantastic. All right. And if there are any other questions from the audience, please continue to type them into the chat. And in the meantime, if you were to recommend a specific resource for our participants to perhaps go learn more about, is there a set of guidelines or any specific resource that you feel would be perhaps the most beneficial or very helpful to our participants?
Actually, this is a very good question. What I'm gonna do is I'm gonna put the main references that I always use, like the CDC recommendations or like American Association of Pain Management. I can put them all maybe in one slide and share it with the participant. Can we do that?
Absolutely. I think that sounds like a great idea. So key references coming your way.
Yes.
All right, and one last very specific question from Mohammed, who asks, in the case of traumatic fingertip amputation by a bullet, which analgesic is the best choice?
Oh my gosh, I have to research this one.
Sounds like a good Pico question.
Yes. So let's also include it in the answer I'm gonna send to the participants. So I'll do some research about this very specific question and get back to you, Muhammad, very soon, hopefully.
All right, fantastic. All right, then, just as we wrap up our session here together, just want to share my appreciation to the audience for being active and asking questions and being involved. We will be sharing with you the form for today's session for your feedback. In the meantime, next week we do have our last session for the CPD series for this year. And this will be on Parkinson's disease with Dr. Adeli, Dr. Soltani, and Dr. Khalil, who will be presenting on a local perspective of Parkinson's disease. So please join us next week at the same time, at the same place for for our last CPD event for the session. Finally, I'll be sharing with you the evaluation for today's session. So please do fill it out and allow us to continue to improve the CPD session. And as a reminder to all of those who are looking for the certificates, that these will be issued 7 days after the event and can be claimed online on the CPD events website. So again, please, Dr. Nouhad, thank you very much for sharing your expertise and experience. I've learned a lot this session. I know that our participants have learned a lot this session as well. And so again, a heartfelt thank you for your help with this.
Thank you very much. Much
All right.
appreciated. Yeah.
Thank you, everyone. Have a great rest of your evening, and we'll see you later.
Thank you. Thank you.
And the link to the evaluation form is available in the chat for everyone.